Yeah, so in this study, we used the Flatiron de-identified health database to examine safety outcomes in patients receiving first-line contemporary regimens for locally advanced and metastatic urothelial carcinoma. So we had just a little over 5,200 patients that we examined between January 1, 2016 and October 2023, those who initiated first-line treatment during that period. And as you know, the field has rapidly evolved. So we've seen, platinum agents followed by maintenance avelumab. We've seen single-agent immunotherapy such as atezolizumab or pembrolizumab, and then most recently EV plus pembrolizumab. So we examined patients in an overall cohort, and then also stratified by 6 regimens. So that would be EV plus pembrolizumab, single-agent immunotherapy, atezolizumab or pembrolizumab, and then carboplatin or cisplatin, plus or minus maintenance immunotherapy, because some patients would have gotten it before the approval of maintenance therapy. So looking at those, we examined 30 pre-specified treatment emergent adverse events, and that list was generated from the list of AEs that were reported in the clinical trials among these regimens. So we did find overall, we looked at crude incidence, and then we also looked at incidence that was adjusted for time on treatment, so treatment-adjusted incidence rate. And when we examined those, we did find higher rates of reported crude incidence for most treatment-emergent adverse events. But we did find that when we adjusted for time on treatment, that those were pretty consistent with what we saw in the clinical trials, so specifically like weight loss, fatigue, rash, pruritus with EV pembro, and then also with anemia, thrombocytopenia, nausea with the platinum-based regimens. So an important takeaway from our study is that you shouldn't just look at crude incidence, you want to adjust it for the time on treatment as well. Now, one thing that we did notice was that neuropathy and hyperglycemia were lower, including crude incidence and treatment time adjusted incidence rate in the EV pembro cohort. Now, because this was the most recently approved regimen, there are only 198 patients in this cohort compared to thousands in the other cohorts. So that is a limitation. But what we posited was that neuropathy may be underreported in the real world because it's difficult to measure, and it's difficult if you're not familiar with using EV as a regimen, which many clinicians that's in the community who may not be familiar with EV because right now it's only approved in bladder cancer. So we suspect that there may be some underreporting of these low-grade adverse events, specifically sensory peripheral neuropathy. So that is how we would explain that one. But again, because the cohort is limited in size due to the recent approval of EV pembro, that I think that may explain it as well. When we look at our treatment dates that we included in this study were January 2016 through October 2023. So if you look at the approval of EV pembro in April of 2023, that was approved in the cisplatin ineligible population initially. So I think we're capturing a lot of those patients. And so we do need longer term follow-up to capture more of the broad population that's going to be exposed to EV pembro. And I think we may see, as people learn more about EV and management of its toxicity, specifically the neuropathy, I think we may see better reporting of that in the real world. Big picture is that this is not a head-to-head comparison of treatment regimens. We know that EV pembro is approved in the US and in Europe as of today for all comers for locally advanced metastatic urothelial carcinoma. However, much of the world, platinum followed by maintenance avelumab is still the standard of care, pending approval of EV pembrolizumab. So it's important to know safety profiles of these drugs. We're seeing a lot of data here in ASCO GU with perioperative regimens. So moving these agents, antibody drug conjugates in combination with immunotherapy or chemoimmunotherapy, moving more towards the perioperative setting in the front line. So when we talk about sequencing, we need to take toxicity into consideration, because a lot of these patients, if they have recurrences later on and are going to be seeing similar drugs with either similar payloads or with overlapping toxicities, safety profiles are going to be very important in helping to guide treatment decisions.
Next one.
Yep.
Yeah.
So I think, yes, as we see a large shift in the paradigm and how we treat urothelial cancers with more advanced therapies moving to the earlier settings, and with more targeted agents with, very specific toxicity profiles and some with overlapping toxicity profiles, I think that's going to come into play in how we sequence agents. So it's very important in having that shared decision-making between patients to know which treatment is the best for each patient. So not only efficacy, but really considering safety and what patients' comorbidities are.